Hi and welcome to Step Strides with me, Connor Ratcliffe. And we're back again, quizzing. So hopefully a fun or semi-fun or at least valuable exercise in consolidating what you've watched in the videos and enables me to talk a little bit more around some of the material. And yeah, hopefully it will be interesting and I suspect maybe the least engaged with set of 3 videos, but that could be the most important bit because it's the reflective consolidation piece. But anyway, maybe it's because I'm not as chirpy as the AI generated narrators, but hey, maybe I'll try and increase my chirp or my American accent. Anyway, let's crack on, shall we? So another 8 questions today on motor learning this time round. So I think probably makes sense that we do these in some sort of order. So if you've not looked at sort of therapeutic aim and you've not looked at sort of ways to modify intensity, then probably look through some of those. But if you're familiar with those, and it doesn't really matter if you're kind of doing them out of order, then motor learning is interesting. And we're kind of looking at this in the context of exercise progression and exercise choice, really. But say first things first, it's probably quite useful to be familiar with obviously what your therapeutic aims are. So what are you trying to do? How you can modify intensity, and exercise choice is kind of one of the ways to modify intensity or sort of break plateaus by changing exercises or progressing exercises. But probably understand those things first and then understand about how we might then progress our exercise or have a little bit more understanding of what exercise we should choose and having an understanding of, you know, the theory behind that, which is what this kind of small little series of explainer videos and sort of reflective quizzing is all about, is useful because it's less about the association of, I know this exercise can be used for insert this pathology or this kind of scenario, because you'll always be kind of exposed to or faced with scenarios that don't quite fit within those neat little boxes, essentially. So having an understanding of why we're doing these things is really quite useful. So the theory isn't just theory for theory's sake, it is, you know, applicable and helps us understand why things are working, aren't working, perhaps, and then how we can change it rather than just the more simplistic approach of I can use X exercise for Y pathology, because that won't always work. Because you're treating people, not pathologies. So let's have a look then. Question 1. Which stage of motor learning is most associated with high conscious effort and a focus on what to do and how to do it? Not really sure why it's put that in inverted commas, really. But anyway. So A, autonomous, B, transfer, C, acquisition, or D, retention. Well, A, the autonomous phase is, I mean, by definition of the word, really, you're kind of able to just do it without too much thought or outside input, essentially, as is our privilege as podiatrists and other clinicians. We are autonomous. We can do what we want without someone looking over our shoulder, which is good, isn't it? But you should also have the required clinical skill to do that. But yeah, which is mostly the case, isn't it? Not always. But anyway, autonomous really relates to B, which is sort of the transfer phase of our motor learning progression. So those two, by kind of definition, actually at that point should have less kind of conscious effort or like cognitive demand associated with them. C, the acquisition phase. Well, that's kind of our first step on our motor learning journey. So it probably makes sense that that has higher conscious or cognitive demand. And it's quite a useful thing to be aware of, I think, because if people have to think about it a little bit more, then there's kind of compliance implications associated with that. And there's kind of the consideration of maybe how hands-on you need to be as a clinician versus how much you trust your patient to go away and kind of perform that exercise. No slight on patients. The more challenging kind of the exercise is, and the more variables you've given them, and particularly if you're in a bit more of like a re-patterny kind of phase. So by its nature, that they're more complex sort of exercises for patients to undertake, because you're almost trying to neurally rewire people, like they want to move and sort of function in a particular way, and you're sort of forcing them to move in a different way. Then it might be that you maybe review them a little bit more often and make sure that you're a bit more hands-on with them to make sure that not just being compliant, but they're performing that exercise correctly, and having that understanding that sort of our initial acquisition phase has that high conscious or cognitive demand kind of enables us to have a little bit more depth of insight into our clinical decision making, essentially. So acquisition seems like a reasonable answer here, and it's kind of associated most strongly with the sort of cognitive stage where patients have to think about it a bit more. Retention is kind of in between, isn't it? So we have acquisition, retention, transfer, and retention's typically more associated with the associative stage. So that's where things are starting to get a bit easier and they don't have to think about it as much, and it's that kind of in the middle practice ingraining process and sort of neuromuscular plasticity phase. So acquisition seems like most likely answer there in our first phase of the motor learning sort of process, and indeed we are right. So this initial stage, also known as the cognitive stage, involves the patient learning the basic requirements of a new skill. And as I say, it depends on like the complexity of movement, their familiarity with exercise generally, you know, if they've done lots of rehab in the past, if they're a high level athlete, do lots of exercises anyway, lots of sort of different exercises, or if they're a bit more sedentary, all those things sort of come into the conscious or cognitive demand acquisition, alongside then like our exercise specific variables. So how much are we giving them to remember, even with a simple tiptoe raise, which sort of the videos make reference to? If you're saying about reps and sets and frequency, and then you're throwing tempo in there, maybe you're increasing range of motion or you're decreasing range of motion because you want them to work within a tolerable range, or you want to, if you're thinking about like Achilles tendon loading, you want to reduce like deep portion compressive irritation of tendon in like an insertional Achilles tendon pathology. Well, that's all a mouthful, isn't it? You know, like, can you remember all those things I've just said? And you've obviously given them instruction alongside that, so there's numbers against all of these words. And even if you've got nice exercise prescription software, or you're writing this down for them, like, that's still a lot of stuff, isn't it, for them to sort of think about. Even if they're reading it, watching it, they've still got to think about all that stuff. The more they do it, as we kind of shift within the retention and associative stage, those things start to become a bit more second nature. But that's with, you know, a relatively simple movement, like a single plane movement that most people will understand. You know, come up on your tiptoes, come down. Like, it's not a complexity of movement with that. But you can see how within this acquisition phase, the more we add, even if it's just around like exercise instruction and ignoring all the patient-specific variables, the more complex it gets. And if we're adding then, you know, more and more cues into this because we want them to move in a particular way, or as I said earlier, we're considering, you know, less about mechanical loading, increasing capacity, increasing, you know, their tolerance or tissue changes, and we're thinking a lot more about we want them to move in a specific way and, you know, use this muscle more and not that muscle. That gets more complex again because they'll really have to think about the way that they're moving. So that's why it's quite important, I think, hopefully with, like the clinical examples here, to have an understanding of the theory behind what's going on, rather than just, well, I've given you this stuff to do, like, why aren't you doing it? You can kind of work out why they aren't doing it maybe a bit more, and it gives you something else to consider around like your compliance, or maybe, okay, I'm going to take some of those exercises out because giving you 5 exercises to do with, different frequencies, different sets, different reps, different tempos, different cues, like, yeah, it's overload. Like, they're just not going to do it. So it helps you with your overarching design, I think, and understanding the patient in front of you and what they can and will reasonably do, and sort of what's fair to them, really. Rather than maybe the more mechanistic view of this of, well, you're impacting, this tissue's got reduced capacity, like I need to initiate the tissue change, like these exercises will do that. Like that's quite a narrow view. Not trying to justify why this is important, I guess, too much, but hopefully illustrating why it is. Question 2. Why is disengagement or incorrect performance most likely to occur during the acquisition phase of rehabilitation exercise? Well, this actually quite nicely follows on from question 1 and our recent conversation, if you were following along. So A, neuromuscular plasticity has already reached its peak. B, the exercises are typically too simple to maintain interest. C, the high conscious effort required can be taxing for the patient. D, the patient has already achieved the autonomous stage. So, as is standard at this point, let's work our way through and sort of consider these. Not just which one we think it's right, but why we think it's right and why we think the others aren't, because that's a useful critical thinking exercise. So A, neuromuscular plasticity has already reached its peak. Well, that's probably towards the end of our associative or retention phase, and really that's like the transfer element of this motor learning progression. So if we're kind of at that plastic stage where we've initiated the changes that we want, and their default is to move in particular ways, because we've ingrained that process through repetition and practice, then really that's actually easier is the point. So that's probably not the right answer here, and it doesn't really relate to kind of the acquisition phase. Essentially, it's the opposite that's kind of occurring there. This is the point where we're trying to ingrain the neuromuscular plasticity. So probably not that, or motor plasticity is sort of synonymous broadly, if you're fumbling around terminology. B, the exercises are typically too simple to maintain interest. I mean, arguably, like this could be a reasonable answer, in fairness. This isn't the one that I kind of wrote about when I prompted these videos, and the one that I was considering, but this is kind of, I suppose, a patient-specific and an exercise-specific consideration, where sometimes if they are used to, competing to a higher level or like a greater complexity of exercise, they're going to the gym 5-6 times a week, they might not want to be doing what they perceive as quite a simple or basic exercise, even if you've tried to kind of educate them and justify to them why it makes sense to do this. Like this is potentially a reason why in the acquisition phase that they might just not be interested, they don't want to do it, they don't like the exercise, so they're just not going to do it, they disengage from it essentially. So that arguably is actually quite a reasonable answer, to be honest, but it's not always kind of typical within this phase. It's probably quite specific, I guess, to particular demographics of patients, and sometimes you actually might be the other way around. You're giving quite challenging and almost awkward exercises to try and get them to move in a very specific way or a different way to how they want to move at the moment. So that could be an answer, but it's probably not quite the right answer in the context of this question. The high conscious effort required can be taxing for the patient. Well, see question 1 in our previous conversation, like we know that this is a thing, and we kind of touched upon like the implications for compliance there. So as a more kind of standard default within acquisition phase, I think high cognitive or sort of conscious effort, like it does put people off. They're not just having kind of to do something that by its nature they almost don't want to do, because they're having to do it because they're in pain and they can't be doing what they want to do. So that's kind of bad enough in itself, and I think that's one of the reasons why you have like these weird barriers around rehab. It's like, well, you know, you're in pain, you've come to me to get out of pain and to be able to do what you want to do, but then you're not doing what I've told you to do. Like that's a weird like juxtaposition, isn't it? Like, why is that happening? And I think the more we kind of drill down into that and like the psychology of it, the more actually it makes more sense than you at first sort of superficially think it should. But one of the reasons around that and picking, you know, compliance is by its nature always actually quite complex, because people are complex and have lots going on typically. You can never really narrow it down to one thing, but this is quite a strong association within the acquisition phase. So if you make the assumption that 9 times out of 10, you are making them do something that they're not used to, at least, and that might just be a tempo that they're not used to. You know, they're used to doing tiptoe raises, but they do as many as they can as fast as they can. It's still something different. So there's always, typically, when you're giving them something new to do, even if it's not a new exercise, but it's new instructions and cues around the exercise, there's always an element of kind of conscious or cognitive sort of taxation at that phase. So that one probably seems a bit more likely, especially given our previous conversation around, or I say conversation, like this is happening in real time. I guess monologue is more accurate. But yeah, I don't know, maybe you're pausing this and kind of having a weird asynchronous conversation with your computer / me. Anyway, the patient has already achieved the autonomous stage. So again, that is more of the reserve of our like transfer phase. So that tends to make things easier, which if it's easier, then you're less likely to get kind of disengagement or incorrect performance. So C is probably the answer here. And it is, that's right, the cognitive load of learning how and what, again, inverted commas, to do makes the movement less natural and more prone to error or frustration. And I think that, like all things, these are kind of general rules. You know, there's always exceptions to rules, aren't there? If you've been in clinical practice for like 10 minutes, you'll see quite quickly, maybe 10 minutes is hyperbolic, but you will see quite quickly there's always exceptions to rules, which is why kind of algorithmic approaches don't work particularly well. And person or patient-centered medicine is kind of more the mainstay of standard of practice, really, and standard of care. So yeah, we move on anyway. I'm tangenting, aren't I? 3. The associative stage of motor learning is primarily focused on which of the following? A. Refining the movement to make it second nature with less deviation. B. Identifying the therapeutic aims of the exercise progression. C. The initial introduction of a new movement or skill. D. Moving the skill to a more complex or demanding environment. Slightly weird use of terminology on environment there, I think. But yeah, maybe. So the associative stage is kind of referring to our second part of motor learning progression, and that retention element. So A, refining the movement to make it second nature with less deviation is in essence a pretty good description of what's going on. So we've introduced it within the acquisition phase, then we've kind of worked with them, or we've sent them away to do it as a home exercise plan, whilst, you know, keeping touch points with them to make sure that it's going well and as we want it to. And practice makes perfect in this movement or exercise that we've asked them to do. So, I mean, perfect is typically an unrealistic goal in most instances, but the adage of, or saying of, practice makes perfect is a pretty good descriptor here, and a less fancy way of saying what we want to happen within this associative or retention phase. So A seems like a pretty good front runner here, and kind of broadly describes what we want to happen in this middle phase of our motor learning progression. B, identifying the therapeutic aims of the exercise progression is kind of something that hopefully you have in mind before you start considering your prescription of exercise, really. So that doesn't really describe this particularly well, I don't think. You should really know kind of what you're doing and what your therapeutic aim or outcome is before you're kind of through this process of motor learning. That happens before you give them the exercise, because the exercises that you're giving them are to achieve this therapeutic aim. So that's kind of a first step, I would say. The initial introduction of a new movement or skill, better description of our acquisition or cognitive phase. And then D, moving the skill to a more complex or demanding environment. Well, that kind of happens at the end of our transfer phase. So once we've acquired and mastered new movement, new skill, new exercise, then we can transfer it across to typically, a more compound or challenging exercise, because they then have the motor skills to achieve that. So I think A is our answer here. This stage, known as retention, involves practice to ingrain the movement via motor or neuromuscular plasticity, and I guess that's kind of the undertone. That's what's going on in the background. Whereas you start to create that, you'll read about like muscle-mind connection stuff, and it interrelates with like maximum voluntary contraction as well. More trained athletes can contract more of the muscle because they're practiced at doing that, and the brain is comfortable with them doing that because there's less risk, perceived risk of sort of threat damage from it. So interesting stuff to have a read around. Number 4, what occurs during the transfer phase that allows a patient to perform an exercise reliably and independently? A, the clinician must increase the conscious effort of the patient. B, the movement becomes automatic and enters the autonomous stage. C, the patient returns to the cognitive stage to refine the movement. D, the exercise is simplified to ensure zero deviation from instruction. So transfer is our end stage, as we've kind of discussed already. And if our kind of end goal here is to have them, we give them the tools, we maybe supervise them a little bit, but ultimately we send them away with said tools to kind of manage themselves, and then we can use those tools for progression if or when needed. Then, some of these are going to make more sense than others. So the clinician must increase the conscious effort of the patient. Well, not so much really. As per kind of previous questions, if anything, that is going to be a little bit of a barrier for them in most cases to complete exercises reliably and independently. Now, that might happen as we enter that transfer and give them a more complex exercise as aligned to our final sort of therapeutic aims and outcomes goals, but it's not the must, and it's not the bit that's kind of helping them to perform those exercises reliably and independently. It kind of happens as a result of being able to do that and then progress to a more complex exercise. So not A, I don't think. B, the movement becomes automatic and enters the autonomous stage. Well, that is really the output. That's the end part of like the transfer phase, and hopefully you can see how these align. If you want someone to do something reliably as instructed on their own without us having to give input, well, you want that movement then to become automatic, and autonomous stage is kind of, again, fairly interchangeable with that transfer phase. So B seems like a likely contender. C, the patient returns to the cognitive stage to refine the movement. Well, that's almost like a kind of a backward step, essentially. So that one doesn't make too much sense. It's describing like acquisition again, like we were giving them a new exercise. So that doesn't really make sense. They don't marry up. It doesn't resonate. D, the exercise is simplified to ensure zero deviation from instruction. Now, this might be something that we do to facilitate an exercise being, more reliably completed. So if upon review, you just, you say, cool, right, show me what you've been doing. Let's have a look for like sets, reps, form. And actually what they do bears no resemblance to what you wanted them to be doing, then this might become, part of your interventive consideration or action, essentially. So rather than just saying, no, you're not doing that right. And, sometimes there is a scenario where you just need to like cue them again, show them how to do it, maybe get them back a bit more regularly, blah, blah, blah. Sometimes rather than trying to kind of keep doing the same thing and expect a different outcome, we need a change of tact. So it might be at that point you think, okay, fine, you're not kind of getting this one's not working for you. Right, well, we can maybe still achieve smaller milestones to work towards where we need to be, but perhaps I need to just simplify this in the first instance to get there. So this might be kind of a way to ultimately get to that like end transfer phase, and it might be just, you kind of break this down and be a little bit more incremental. You were maybe a bit ambitious to begin with. And that would potentially facilitate like exercise completion more reliably and independently, but still kind of the actual what of the question here, and the what is occurring during the transfer phase, that probably is better described by B. So let's have a look. Yay. Okay. I've done a few of these now, and at some point I'm thinking I probably will get one of these wrong, because these are like the first time I'm looking at it as well, but eventually I'm sure it will happen. And I'll be at odds with myself if you're worrying that you're getting it wrong at home. Like, don't. That's the point of learning, isn't it? You don't learn if you don't get it wrong. So the movement becomes automatic and enters the autonomous stage. Transfer relies on the movement being ingrained so well that it requires very low conscious effort. And yes, it becomes kind of second nature, essentially. Number 5. In the provided clinical example of balance deficits, why would a clinician prescribe a wall-supported heel raise before a free-standing one? For any of those watching who have been in my teaching clinics or taught sessions, this is a particular bugbear of mine, that people conflate single limb stance and single limb tiptoe raise on like their assessment, and then it irritates me. It's like they can't do a single limb tiptoe raise, and so they can do a single limb tiptoe raise, they can't do it freestanding. They're independent, different things. Anyway, that's a me problem, innit? Let's have a look at these. A, because heel raises cannot be performed without hand support. B, to ensure the patient reaches the associative stage faster. C, to separate the load and objective from the balance deficit. D, to decrease the range of motion required for the Achilles tendon. So in like the notes that I wrote for this, this kind of refers to the fact that when we consider what maybe we might perceive as simple exercises, there's always like an element of actual, you know, like relative difficulty here. So to perform a tiptoe raise, particularly a single limb tiptoe raise, without like support is actually quite a challenging skill, because it requires a relatively high degree of balance as well as the actual, you know, primary movement of plantar flexion, essentially. So when we look at these, because heel raises cannot be performed without hand support, well, that's patently not true. Yes, it will be very challenging for a lot of patients, but when, you know, you're assessing for this and seeing if it's an appropriate exercise, to do that without holding on to something shows that you have good balance as well as, you know, the strength in that plane. Like you're kind of testing two things. It's a much more complex movement than a supported heel raise, and if you're ever using what can ultimately become exercises, but you know, that movement as an assessment, then that, as per my previous example, gives you a different finding. It's the difference between saying, you know, they can't balance or they can't perform a tiptoe raise because they can't do that movement, versus separating out the two and independently looking at, you know, balance tests and strength tests. If they can do both of those things, then yeah, combine it. But that's the whole point of understanding like this motor learning progress and process, and the phases that, you know, sometimes they live independently of each other, and you need to work through that acquisition, retention, transfer process to then put them together. Some people will already be at that point, a lot aren't. So yeah, because heel raises cannot be performed without hand support, like that's not the answer here, but that is true in a lot of cases. To ensure the patient reaches the associative stage faster, not really. I mean, maybe there's an argument, like most things, you probably can argue your way around it if you want to, because if it's just too challenging, then arguably they're never really going to get past that acquisition phase to reach the associative stage. So yes, I suppose to a degree you could argue by making the exercise simpler and appropriate for the patient, then they will reach the associative stage faster. But that's not really what I was getting at when I wrote about this, and it's not really the point of this question and the answer, really. The point of this is see that you may need to, in a lot of cases, separate the loading objective from the balance deficit. You may not need to, but in this question, where you have a patient with a balance deficit, that doesn't mean that you can't get them to do a tiptoe raise. It just means you need to separate those two things out and focus on them independently before you can transfer them together for the more complex exercise. That's the point that I was trying to get at. So C seems like the obvious one from my mind, at least. D, to decrease the range of motion required for the Achilles tendon. I mean, again, like this probably would be true, because if you have a balance deficit, one, it will be quite difficult for you to perform this, but you're probably going to have multiple planes of motion going on, which arguably would increase sort of the total range of motion, even if it doesn't kind of increase just the sagittal plane for every single rep. So yes, if you do separate these out and you get someone to do kind of a wall supported heel raise, the likelihood is you're going to decrease the range of motion in like frontal and transverse plane. You're going to decrease the range of motion in the frontal and transverse planes, but that again isn't really the reason that you're doing this. C is. So, like all things, there's some interesting thought experiments and conversations to have here. And if you're thinking some of these other ones, like there's some like justification and rationality for you to do so, but not really the primary answer, like especially when we have like the balance deficit here. It's not the main reason that you're going to get them to hold on to a wall. But in some scenarios, you could argue this is a side effect also. So let's go with C, because I'm pretty confident on that one. So yes, isolating the tendon allows the patient to acquire that specific movement before transferring it to a balance dependent or a more balance heavy task. Which of the following is cited as a reason for isolating components of a compound movement like a lunge? A. Open chain exercises are always superior to closed chain lunges. B. A patient may have specific deficits, such as sagittal plane deceleration, that need training before integration. C. Lunges require no conscious effort once the acquisition stage is over. D. Compound movements are ineffective for strengthening the quadriceps. So this is an interesting question, and hopefully I'm aware that maybe this sounds like I'm just ranting a little bit to camera sometimes, especially previous question, but hopefully it's not coming across too much like that. If it is, like, yeah, acknowledged. Self-aware at least, even if I am ranty. So yeah, which of the following is cited as a reason for isolating components of a compound movement like a lunge? Well, open chain exercises are always superior to closed chain lunges. Probably doesn't really make sense, to be honest, and also not true. I mean, superiority of exercises is probably a contentious area for debate, because arguably it doesn't exist. You know, what's a hierarchy of superior exercise? It's a bit of a nonsense, really, because that depends on so many variables. Who's your patient? What you're trying to achieve? Sport-specific things. So I think just the fact that it sets this out as a superior to probably rules it out, doesn't it? But this is, you know, not the reason for isolating components of a compound movement like a lunge. Sometimes you don't even need to isolate the sort of components either. Again, it depends on the person in front of you. Some people will really be easy for them, they'll be able to do it. Lots of others, not so much. It's why our assessment matters, doesn't it? And why the individualisation matters. But A, open chain exercises are always superior to closed chain lunges, not true. Both can be good. Sometimes one will be superior, sometimes the other will be superior. It depends on the scenario and the context and the patient and all those things that I was bang on about. B, a patient may have specific deficits such as sagittal plane deceleration that need training before integration. This is not always the reason, and there's other reasons. Again, like you can cite balance here, or lack thereof, like balance deficits, and why you might separate that out. A lunge typically requires an element of, you know, or a reasonable degree of proprioception and balance for the sort of landing mechanic element of this, and you're landing in, you know, a relatively like complex position, I guess. But this would be another argument that actually you're not particularly good at sagittal plane deceleration, and that could be within a number of like muscle groups here, but primarily let's consider sort of the quadriceps doing this, and then you're going to have like gastrocnemius, soleus as well, who are involved to kind of decelerate anterior translation of tibia, fibula over foot. So if you're not particularly good at that, then it might be that you need to train those muscle groups independently to begin with before there's a more complex motor pattern working around, you know, multiple joints. We've got hip, knee, and foot and ankle that are all under consideration and control here. So this is the more like overarching rationale for why you might do this. It's where you feel that the patient might have a deficit in a particular movement or a particular group of structures or pain within them that makes that more compound movement much more challenging to achieve. So rather than just kind of giving up, we might just break it down a little bit, work through our motor progression, and then bring it back together so they can then use them all together. If they're like in this example, you know, if one group isn't maybe pulling their weight particularly well, then, and I mean, you know, you can consider like your hip extenders here as well. As you go down into the lunge, like they'll decelerate the hip flexion element of that movement as well. Then those other muscle groups maybe take over. You get like pattern specific inhibition maybe as a descriptor of this, where certain groups do the lion's share of the work because others don't work very well, and maybe then you're training potentially like a bad movement pattern and opening up to overload kind of, or overuse sort of injury mechanisms. So yeah, this is the point of it, is that you should just consider the more challenging the exercise is, there's multiple players all doing different things at different joints at different points of the movement, through different phases of contraction as well. Like that, even though lunge, I think, you know, bodyweight lunge might be considered as a simple exercise and handed out to people routinely, it's not really. Like there's quite a lot going on, especially in a patient who has pain, deficits or other biomechanical things going on as considerations. So it's just to sort of look at these things through a different lens, I guess, and then give consideration to it. So B makes sense to me. C, lunges require no conscious effort once the acquisition stage is over. Again, like everything always requires some conscious effort, it's just how much. So that doesn't seem true. And then D, compound movements are ineffective for strengthening the quadriceps. Again, that's probably a bit of a falsehood there. Like compound movements are really effective in some instances for strengthening the quadriceps. Isolated movements are also really effective for strengthening the quadriceps. So again, this isn't a better, worse, either or. It's going to be different for different people, and some of that's just about what people want to do, what they're comfortable with doing, and then some of it's about what they can do. So yeah, isolation exercises can be really effective, but you can also strengthen quads with compound movements like squats, for example, or lunges. So yeah, it's not that they're ineffective. They might be for some people, but that's a sweeping statement, isn't it? And also doesn't really relate to the question here. Wouldn't be a reason for isolating kind of the components of a lunge, to be honest. So let's see if I'm right. Yes, training specific elements like balance or eccentric control separately allows for better acquisition before transferring them into a complex lunge. And yes, I would tend to agree with that, but it depends on your assessment of the patient as to, you know, the specific context, scenario and appropriateness of applying these concepts. Number 7, nearly there. According to the text, which factor contributes to the complexity of an exercise and might lengthen the learning timeline? A, the patient's previous history of high compliance. B, the use of single plane movements only. C, multiple joint involvement and multiple planes of motion. D, a low number of prescribed cues. So essentially what we're looking for here is what's going to make this more challenging for the patient. So what's contributing to complexity of an exercise that's going to make this process, again, typically a bit longer because it's not a set time frame. You know, different people will sort of progress through these phases at different rates, loads of variables that influence it. And this is just looking at one, essentially. So which factor makes it more complex or more challenging? Patient's previous history of high compliance, well, not always. If you've got historically a compliant patient, that's probably not going to make it more challenging, more complex, and kind of lengthen the learning timeline. There's nothing to say that, you know, history will be an indicator of current or future like outcomes and compliance in this instance, but probably not going to be a bad thing and add to sort of the complexity of the exercise by any metric. The use of single plane movements only, again, single plane movements typically easier and less complex. Multiple joint involvement and multiple planes of motion, well, through virtue of single plane being easier, multiple joint, multiple planes of movement, typically more complex and harder because you've got more structures involved, more to think about, and particularly to fatigue, you know, different groups and different levels of control kind of changing and fatiguing over time, potentially at different rates. So this adds almost always increased complexity, I would suggest. A low number of prescribed cues, well, again, if you give less things for somebody to think about or do, then that's not making it harder, is it? If we gave them lots and lots and lots of instructions and cues, well, that would increase complexity. So C seems like the answer. Increasing the number of joints and planes add more variables for the patient to coordinate, increasing cognitive load. Makes sense to me, but then I did write it, so I guess it would. What is the relationship between Romanian deadlifts and conventional deadlifts in the context of motor learning? I mean, there's probably a few here, but I guess from the material supplied in the video, A, the hip hinge movement from the RDL can be transferred to improve the conventional deadlift. RDL should only be used if the patient fails the transfer stage. There's no motor learning relationship as they use different muscle groups. RDLs are the retention phase of the conventional deadlift. For fun, in the end of this video, I'm going to work in reverse. D, RDLs are the retention phase of the conventional deadlift. No, they're not. Essentially, they're different exercises. They are different exercises, even if they share sort of similarity. They're not. That's a misunderstanding of the material, essentially. So, not that one. C, there is no motor learning relationship as they use different muscle groups. They use quite a lot of similar muscle groups, essentially. So, like, you know, posterior chain stuff, they're quite heavy on that. Both of them, you know, core, like, bracing and stiffness and control, again, both quite heavy on that. So doesn't seem like that one because there's quite a lot of crossover similarity in the groups that you're going to be using. RDLs should only be used if the patient fails the transfer stage. Again, it's probably a bit of a weird way of looking at it, to be honest, and a weird way of phrasing it, I would suggest. So probably not that one. It's kind of harder to interpret what that's getting at, to be honest. RDL should kind of be used because of your clinical assessment and judgment and trying to achieve a therapeutic aim, which kind of leads us on to the hip hinge movement from the RDL can be transferred to improve the conventional deadlift. It trains a movement pattern, essentially. So you can very specifically have an outcome and a goal from this as sort of, it's a good exercise in itself, but you can use it as like a bridging exercise, essentially. So if that's the component and the element of their deadlift that they're struggling with, well, let's use this different exercise to still achieve a training effect, but, you know, an overarching sort of therapeutic aim where rather than just modifying the deadlift, which is another way of doing this, and you could just cue the deadlift and, you know, reduce weight and look at like different deficits within that movement. Absolutely, that's valid as well. But this is another way of doing it, like giving them a different exercise that, you know, they can perhaps perform a bit better because it's a different movement, but there's that hip hinge element that can be trained and then progressed on, because you start from sort of a different position and you're sort of lowering down as opposed to lifting up from the ground with RDLs to like conventional deadlift respectively. It enables you to perhaps like incrementally change and train that like hip hinge pattern through kind of increasingly progressive range of motion. So it might be that you still modify the RDL a little bit to achieve this outcome, but that is a thing that you can do again, and uses, you know, perhaps slightly more complex exercises, and aligns maybe better to patients who are a bit more gym based and used to doing like gym exercises and maybe don't want to be doing more conventional like rehab exercises, although I think the line and descriptor on those is quite blurred and probably open for debate as well. But in this instance, and sort of what answers we get here, whilst you know you can train a number of different things because of the similarity in like muscles that are engaged with these exercises, you can train the hip hinge movement with your RDLs, and then look to transfer that across into improving maybe your conventional deadlift form. And that's right, mastering the hinge in a simpler or modified movement like the RDL provides a foundation for more complex lifting patterns. And that's the end of our quiz. Another 8 questions done, and made it last another 45-50 minutes, which again, if you say in my lectures, you'll know I'm quite good at doing that. So hopefully you've enjoyed this and made it to the end of the video. Who knows, I'm sure YouTube analytics can tell me, but we'll persevere for now until I decide maybe I need to change format. But yeah, this is a useful process to kind of consolidate your learning rather than just kind of background listening to the videos. Internalize it, consolidate it, think about it, because that's what's going to help you in clinical practice. And that's kind of the idea of continued professional development and this whole reflective element of learning. So yeah, this gives you an opportunity to think about it, not just listen to it, I guess is the aim at least. If you did make it to the end, thanks for watching, and yeah, check out some of the other videos. Cheers.